Welcome back to Catalyst University. My name is Kevin Tokoph, and in this video, we're going to be discussing a clinical prediction rule that can be used to determine whether or not a cervicothoracic junction manipulation can help somebody who has shoulder pain. And this comes from a paper titled "Some Factors Predict Successful Short-Term Outcomes in Individuals with Shoulder Pain Receiving Cervicothoracic Manipulation, a Single-Arm Trial." And you can see the authors right here. And as I mentioned in other videos, when they're trying to determine a clinical prediction rule, they measure a bunch of stuff, objective findings, they have a bunch of subjective reports by the patient, and they basically get all of them together with a sensitivity and a specificity, and they try to boil this down statistically to a limited number of criteria that's easy to manage, and then however many of those are positive or yeses, it gives you a probability that this intervention will help the given impairment or problem, okay? So they started with all these right here, and then they boiled it down to 5 factors, as you see right here. So one is, do they have pain-free shoulder flexion below 127 degrees, okay? That basically means they're doing shoulder flexion. We're good, we're good, we're good, we're good. Here's 90 degrees. You keep going, we're good, we're good, we're good. Oh, and then I get to maybe 135, and then there's pain. So as long as it's pain-free under 127 degrees, that's a positive. They have shoulder internal rotation less than 50 degrees at 90 degrees of abduction. So you're at 90 degrees of abduction, you measure how much internal rotation they have. If it's less than 53 degrees, that's a positive. A negative NIR test, okay? We've discussed NIR tests in other videos, so take a look at that if you want more information. They're not taking medications for their shoulder pain, and their symptoms have been there less than 90 days. Now, the pretest probability here is 61%. That means if you have a patient coming into your clinic with shoulder pain, you know nothing about them, you just know their shoulder hurts, and you know it's a shoulder issue. The probability that a CT junction manipulation will help them is 61%, which right off the bat isn't bad. It really means that if somebody has shoulder pain and you do a CT junction manipulation, most of them are actually going to get some benefit out of them. But we'd like to be a little bit more precise. So we have the post-test probabilities. So if 3 out of 5 of these are positive, the post-test probability jumps up to 90%. So 3 out of 5 are positive. There's a 90% chance that a CT junction manipulation and probably CT junction interventions afterward to reinforce it are going to help with their shoulder pain. If 4 or 5 of them are positive, even just 4, it's 100%. So if you have 4 of these, you definitely should do a CT junction manipulation. Now, that's obviously not all you're doing. You might have CT junction exercises that help reinforce it, like I mentioned, and really treating all the impairments. But the manipulation should be a part of your treatment plan, okay? Now, going forward from this, you do a CT junction manipulation. This is one example of one. It's not the only one. And what you see here is, in blue here, is the non-success. So these are the people that got a manipulation, but they did not satisfy the clinical prediction rule. The success ones in black here, these got a manipulation, but they did satisfy the clinical prediction rule. And this first graph right here is basically an immediate remeasurement. So test, treat, retest model. You measure shoulder flexion, right? It's a certain value. You do a CT junction manipulation, and then you remeasure shoulder flexion, and sure enough, it's increased. Okay? In fact, it increased in both of these groups, but it increased more in the people who satisfied the clinical prediction rule, as you see right there. Now, the second graph is looking long term, so basically around the time of discharge. You can see here that they both get to the same value, right? So the people who got the CT junction manipulation but didn't satisfy the clinical prediction rule, they get to the same point as the people who did satisfy it. So you say to yourself, well, if they get to the same point, then why would I do this manipulation, right? I mean, yes, you can see in the short term you get more flexion, which might help some things, but in the end, everyone got to the same point. So what's the big fuss over a CT junction manipulation? That has to do with overall function overall disability. Okay, so the SPADI right here, this is the Shoulder Pain and Disability Index. It's basically like the Oswestry or the NDI, but it's just specific for the shoulder. And you can see here in the ones that did satisfy the clinical prediction rule, so the black ones, they have a lower score here. And in this one, since it's a disability index, a lower score is better. So you can see here the ones that didn't satisfy the CPR, they still fared well, but they had more disability than the people who did satisfy the clinical prediction rule. Okay, and you can also see here their overall pain score is less for the ones who did satisfy the clinical prediction rule. So it is very important in people with shoulder pain to determine whether or not they satisfy this clinical prediction rule, because if they do, if they've got at least 3 that are positive, there's a good chance that this CT junction manipulation can help them. Not just getting more shoulder flexion, but also having less disability or perceived disability and less pain at the end of their course of therapy. Okay? So hopefully this video gave you a good understanding of this clinical prediction rule and why it's important to look at these criteria and to apply this manipulation appropriately, because you can help a lot of people long term. Please make sure to like this video and subscribe to my channel for future videos, and hit that notification button for notification for all videos in the future. Thank you so much.